Welcome, everyone. And thank you so much for getting along this evening, both in person and online. My name's Sue Ward, and I've got the privilege of chairing this evening's event. My background's in general nursing and then children's nursing for the past 4 decades. I was just saying to Lucy, she could have interviewed me as part of her historic work that she's been doing. And I retired a little while ago after working as Director of Nursing for Children in Manchester and also then the Group Deputy Chief Nurse. So it's great to stay involved, to be able to do things like this. We're here tonight at the Royal College of Nursing HQ to launch this event as part of the Being Human Festival. And that's the UK's National Festival of Humanities. So again, thanks to the RCN team and to the London School of Hygiene and Tropical Medicine for organising the event. And as many of you know, the RCN is a UK membership organisation, professional body and main trade union for nursing. But it's also great to see lots of people from around the world and people who aren't nurses joining us this evening. So just before we get going, how many nurses do we have in the room? Excellent, excellent. We've got some nursing representation, but mainly people who aren't nurses, so that's great, that's what we like. And how many young people have we got that have come along because we're talking about young people's voice? Excellent, so you're so welcome. So, I hope those that are here in person have had a chance to view the Once Upon a Time exhibition, the history of children and young people's nursing. If you've not, please do try and get down to the library and have a look at that. And I've had the pleasure of having time to be involved in with the RCN team to design and curate that. So that's been a real pleasure. So before we get going, I've just got to say a few words on housekeeping. So for colleagues that are here attending in person, there aren't any planned fire alarm tests. So if the alarm does sound, then please do exit the building through the nearest fire exit, and that's to your left or at the back of the room. And the muster point is just inside Cavendish Square. And the toilets are through the doors on your left, and I think there's an accessible toilet out through the door at the back as well. Okay, so for those that are joining us on Zoom, people will be muted through the course of the event, but there will be an opportunity to ask questions using the Q&A function on Zoom. And if you do have any trouble with Zoom, then please just pop a message in the chat, and one of the RCN team will pick that message up and try to sort things out for you. And I suppose just to say, please do remember that the chat's a public forum. Okay, so without further ado, I'd like to introduce Molly Case. Just looking where she'd gone. There she is. So Molly is a spoken word artist, writer and a nurse. She was born and brought up in South London. And in 2013, Molly achieved national recognition after performing her poem, Nursing the Nation, at RCN Congress. And following on from this, Molly's performed her poetry up and down the country, across Europe and at Glastonbury. She's recently, it's quite a while ago now, isn't it, published a book, How to Treat People. That came out in April 2019 with Viking Penguin Random House. So if anybody's would like to read more of Molly's work, that's the place to go. Okay, so over to you, Molly. Thank you.
Thank you very much, and good evening to everybody that's here in person and everybody who's listening, tuning in online. So thank you for the introduction. My name is Molly, and I'm currently working as a palliative and end-of-life care nurse. I'm an adult nurse, but I have some experience of looking after young people involved in transition services, which hopefully will come up a bit on the panel. I was delighted to be asked to write a poem for the Being Human Festival and for this particular exhibition. And as with any commission, as an artist, as a writer, you have to ask yourself whether it's your story to tell. I'm no longer a young person, unfortunately for me. But I was lucky enough to be meeting lots of different people who equipped me with kind of voice banks of young people, kind of be in touch with people that know a lot more than me, and also using my creative license to kind of create a composite of voices. So the poem that I'm going to perform for you this evening is called The Stories That Make Me. And just as an aside, I was a child when I had some really awful, got my mum in the house, so my mum will remember, some really awful, a very rare disease when I was a child and had to have surgery and had a lot of issues, so my own experience as well. But this poem, The Stories That Make Me, it's split into different voices across 100 years. And it was almost supposed to be a little bit like Peter Pan kind of flying over London or flying over the whole of the UK, to be honest, and seeing what was going on over 100 years, that kind of vibe of different voices kind of popping up all over the place, different stories of illness, of health, of surviving, of resilience. So if it sounds a bit messy, it's kind of meant to. And I really hope you enjoy it. The Stories That Make Me. If you come a little closer, we'll show you around a history, a timeline, secrets that we found, like the medicine spoons we use to hide our breakfasts underground. Come now to Wardour Street, Soho, though you'll have to use the back door and be sure nobody sees you, all pustules and fever. Here then, inoculations and general dispensary. This January has been the worst. Just look at the unmerciful ravages of smallpox and disease on little ones as small as these tickets will get you to Paris. 1602, cold cot, hot soup, snow falling on the Rue de Sèvres, red dress from Père Noël, how long we'll be away from Mama? Only time will. Tell me, which way is London? Second to the right and then straight on till morning, but you'd better take an umbrella, the skies there are pouring. Great Ormond Street, 10 beds, a place to rest a headache, tea break, and the nurses tell us their stories of tropical diseases and diagnoses of tuberculoses that make us hide beneath our beds until tea time comes round and our bellies groan to be fed up. Seems children's nurses are being left out again. Why do they have to beg to be properly trained and given nursing registration? Can't people see the years of patience and skill to look after us at our sickest when we are so very... Illness is neither an indulgence for which people have to pay, nor an offence for which they should be penalised. War is finalised, over. So many poor souls resting their heavenly heads whilst Anirin Bevan is dreaming about free hospital beds wheeled on to the balcony again. The River Tor, Swansea rain, gold injections and TB sunray treatment, frequent visits from Joey the rat, whose belly is fluffy and round. Here the streets are made up of boroughs and territories, county lines that no one sees, friendships that just let us be original G's, original me, freedom from rules and regulations, teachers that criticise and don't have no patience, skip school, a light here at a better destination. Ward 3. Sickle cell means I know my blood better than you. The way the cells change shape, the way the walls won't move. Soon, you'll tell me again. You don't look like you have pain. Feign frown, feign scream, make them believe a word I say, but maybe today I'll be listened to, and I'll find I do have a voice inside this. Babies to toddlers, children transitioning to adulthood, we should be treated with autonomy and respect. Expect kindness and trust, not just seen as a condition nor a disease, but a life as unique as the stories that make me, me. Thank you.
Wow, thank you, Molly. I think that that really kind of summed up in a few minutes lots of experiences. Okay, so I'd like to welcome Dr. Janet Weston now, who's Assistant Professor at the Centre for History in Public Health at the London School of Hygiene and Tropical Medicine. And Janet's going to tell us a little bit about the Age and Care Network. There she is.
Thank you very much. I am going to be very brief so that we can move on swiftly to hear about some fascinating research. I'm Janet Weston. As Sue said, I'm the Director of the Centre for History and Public Health at the London School of Hygiene and Tropical Medicine. And I'm also a member of a research network which has helped to organise this event. It's a research group called Age Care and the Caring Crisis, and it's funded by the Birkbeck Institute for Social Research. And it brings together academics and others who are interested in thinking about how people at all ages and life stages engage with care systems, both as recipients of care and as providers of care as well. And very often that network ends up focusing on older people receiving care. So we were really excited to be a part of this event tonight, taking the opportunity to focus on younger people for a change. And on that note, I'm really pleased to be able to introduce our next speaker, Lucy Walsh, who is a PhD candidate at Newcastle University, carrying out some fascinating research looking at treatment and experiences of childhood cancer in the period from 1945 up to about 1990. She's been carrying out oral histories and is still very much in the market for hearing from more potential interviewees in case anybody's interested, whether in a professional capacity or in a personal capacity. And she's going to tell us a little bit today about her research on childhood experiences of cancer. So over to you, Lucy.
Thank you. So I'm going to try to give an overarching idea of what a cancer patient's treatment or options might look like from 1945 to about 1990. So in the 40s and 50s, there are very few treatments for childhood cancer. It's a rare disease, and with little centralisation and specialisation, individual paediatricians don't see enough children with malignant disease to kind of build up the experience of how to treat it successfully, and some are actually morally opposed to doing so. Children with solid tumours might undergo quite radical surgery with some radiotherapy, but quite often with little success, and medical journals largely report either losing sight of children or their discharge home and death within a few weeks. Leukemia, the commonest childhood cancer, was invariably and usually rapidly fatal until the late 1960s. In 1962, American paediatrician Donald Pinkel initiated the first curative approach towards leukemia, consisting of intensive chemotherapy followed by cranial irradiation. And many British doctors who had an interest in treating children with cancer and had completed fellowships over in North America wanted to adopt a curative approach here, but faced resistance from paediatricians who were reluctant to subject children to these really hard drug regimes. So paediatric oncologist Professor Martin Mott sums up the issue. He says, the treatment that was required was pretty unpleasant. A lot of paediatricians argued, why are you putting these children through that? And the answer seemed to us to be that it was a price worth paying. If you had a chance to return them to a normal life, that was a heavy debate. So this is before the advent of resident mother schemes. And so these intensive treatments would mean children spending weeks in hospital away from their families with all the awful side effects of chemotherapy and very little prospects of cure. Paediatricians felt that it gave parents false hope, and that even if you could get these children into remission, they inevitably relapsed. So treatment was really only prolonging the illness and the parents' agony. But in 1968, Pinkel reported remissions of 3 years, and it became more apparent that leukemia was going to be a curable disease. And so doctors imported these more intensive chemotherapy protocols. In the 70s, clinical trials into various childhood cancers really accelerate in the UK. This is boosted by the establishment of the UK Children's Cancer Study Group in 1977. And this is a group of this new breed of doctor, the paediatric oncologist, and they kind of get together to organise and run clinical trials in initially 7 centres around the country. And it goes some way to ending the lottery that had thus far characterised children's cancer treatment. Founder member Professor Sir Alan Craft could reassure parents, we're part of the UK CCSG. Wherever you go in the country, you will be offered the same treatment. And he says that this gave people a lot of comfort. It wasn't just me deciding what treatment we should give. Nurses also specialised in the supportive care that was necessary to deliver these really intensive protocols. So managing infection, managing the other awful side effects of chemotherapy, generally nursing more children because more children are surviving for longer who are sicker. In 1983, they formed the RCN Paediatric Oncology Nurses Forum to share in a more formal way this experience that they'd been building up on the job. So with the advent of these specialist centres, children are spending longer periods in hospital, families are travelling further distances for treatment, and so paediatric oncology develops as a multidisciplinary specialty that aims to care for the whole family's psychosocial well-being as well as the new clinical needs of these young patients. So play specialists, for example, help children through treatments. They could act out procedures with them. There's a picture here of a Hickman teddy, which is fitted with a Hickman catheter. Just as an aside, this catheter is implanted on most children undergoing chemotherapy from the sort of mid-1980s onwards, and it absolutely revolutionises their experience of care. As many of you will know, it means that children don't have to have repeated needle pricks every time they have a chemotherapy or other medicine administered or blood taken. So this really helps in children's experience of these intensive protocols. But provision on the wards for teenagers arguably lagged in the 80s and 90s, although we do get the establishment of the Teenage Cancer Trust in 1990. So recalling the ward teachers' visits, one interviewee told me, I used to pretend I was asleep. You're 14 years old and gluing bits of tissue paper together. Dedicated social workers funded by the Malcolm Sargent Fund appeared on wards in 1976 and provided emotional and practical support to the whole family. They help in so many ways. So they might arrange a babysitter for siblings so that parents can take a sick child to clinic. They supplemented families' food budgets to accommodate, unpredictable appetites following chemo and steroids. They also, though, fund trips away for families to relax together and generally act as counsellors. And charity's been instrumental in the delivery of paediatric oncology services since the specialty's inception. And it's the Malcolm Sargent Fund and CLIC, which was established in 1976 by parent Bob Woodward, that provide overnight accommodation for parents near hospitals. So there'd been growing pressure since the 50s to allow parents unrestricted visiting of their children while in hospital. And by the late 70s, from the interviews I've done, it seems that in cancer care, at least, nurses really do welcome parents on the ward. They want them to be with their children, but there's actually just not provision for them. So Bob, whose son Robert died in 1977, was moved by the sight of parents sleeping in corridors to be near their children. And the home from home that his scheme provided proved a pioneering and practical aspect of care in the UK. It allowed parents to be near hospital, to continue that parental role, but also to get some rest at this really demanding, fraught time. Parents, and it is mothers in particular, become increasingly involved in their children's care, both as wards adopt freer visiting, but also as these intensive chemotherapy regimes see nurses more reliant on parents for some of the kind of basic care. But as children survive longer and centres make efforts to discharge patients home, parents and teenagers themselves actually come to take on quite complex aspects of nursing. So they would be responsible for the care of their Hickman lines. Interviewees treated as teenagers state that this involvement in care gave them some feeling of control at a time when they really had none. But they were a huge infection risk, and so their care could be quite a daunting task. They demand strict adherence to aseptic technique, which, again, some of you will be aware of. It's just making sure you don't get any bacteria on the line when you're flushing or redressing it. Parents also needed to monitor their child's health in between clinical appointments, particularly looking out for signs of infection, which could be really dangerous in these immunocompromised children. And while parents were generally really pleased to be out of hospital with their children, and they've described trying to get on with normal family life, they often felt alone and anxious. And one mother even described it as a traumatic time as she learned how to cope with her son's illness essentially on her own. In 1986, again with charitable funding, Great Ormond Street set up an outreach team to visit children in their own homes and liaise with local hospitals and community health teams to build up the confidence of these teams and then, in turn, the families. The team's main role, however, was to provide palliative care to children whose treatment options had ended and were leaving the specialist centre, which had provided so much support. By the 1980s, focus in the specialty was firmly on cure in most cancer types, but there was little provision of pain management and psychosocial care for children, for the roughly 40% of children whose cancers weren't curable. Besides the phone number of the specialist centre or the local hospital, parents of dying children had to rely on what could be quite patchy help from GPs and district nurses who had little experience with dying children. Mary, whose son died of cancer in the late 1980s, stated, "As soon as we stepped out of Great Ormond Street, that was the end of something being round you. That was really scary." And her husband echoed, "It was really good support when we gone up. It's just ended as soon as you come out the door." The outreach teams, which developed quite quickly throughout the country, set up syringe drivers for pain management, and they helped with care such as washing or wound dressing. They generally act as a bridge between the centre and the home. Anne and Alex, parents of 5-year-old Joe, who died in 1989, described the service as reassuring, and their outreach nurse became incredibly important to them and Joe in the weeks before his death, but they did acknowledge that they felt lucky that service was available to them because it wasn't everywhere. So cancer outcomes were becoming less predictable as treatments improved. So many of us will be familiar with the psychological toll of the process in cancer of treatment, remission, and then waiting for either relapse or cure. As more children who in the 50s, 60s, and 70s would have died within weeks or months are now achieving remission but won't necessarily be cured, attention is paid to the psychological impact of this phase. It's termed Damocles syndrome. It's this constant, uneasy background fear of recurrence, which leaves you unable to enjoy your current good health. Whilst a lot of the survivors that I've spoken to report having coped quite well in remission, I think parents maybe were generally more anxious, and some of them even hesitated to use the term cure in our interviews, which is 40 years after the, apparently successful treatment of their children. Attention's also been paid to the long-term effects of these treatments, and in the late 90s, oncologists sought to target and refine treatments to avoid lasting damage to children's bodies, fertilities, and mental well-being. So the burden of treatment was and continues to be heavy for children and young people. The 1980s see a huge advance in survival rates, but this raises a lot of questions about the ethics of treatment, cure, and recovery. The 1980s have, though, been termed a golden age in children's cancer care by some of the professionals that I've spoken to. Clinical trials were showing great results, and the efforts of the multidisciplinary team in the specialist centres provided wide-ranging support to promote families and children's well-being and their long-term adjustment. And it's this aspect of cancer care, as much as the scientific and clinical advances, that I'm interested in my PhD. Thank you.
Thank you. I mean, I don't know about you, but I could have just carried on listening to that for the whole evening. I think it's a really fascinating project that Lucy's working on, one that we could all learn a lot from, really. So I'm looking forward to seeing the outcomes of your work. Okay, so for the next half hour or so, I'm going to invite our panel for the evening to come up to discuss the children and young people's families' lived experiences and engagement, but from the perspective of the arts, the humanities, and from nursing approaches. And after the discussion, we'll have some opportunity for some questions as well. So our panel tonight's going to be Molly, and Lucy, that we've already met. And then we've also, there she is, we've got Emma Sparrow with us, who is the head of Children and Young People's Engagement at the Royal College of Paediatrics and Child Health. And Emma leads on Children and Young People's, leads the Children and Young People's Engagement team, working to empower children and young people to inform and influence healthcare. So before we get going on the panel, Emma's going to come up to give us an update on some of the Royal College of Paediatrics and Child Health initiatives. So over to you, Emma. Thank you.
Okay, thank you for inviting me to come here today. I'm going to try and do a little bit of sign language because I learnt it years ago and I saw that there was interpreters and I should be trying to do sign language at the same time. So hello, my name is Emma and I work, as you've just heard, at the Royal College of Paediatrics and of Child Health. And my kind of like role is as a youth worker. And that's where I'm going to stop. I'm going to hand back over to the interpreters because that's just like making me nervous now. So I'll keep my hands behind me. So I've got an amazing job as someone who heads up a team that is able to work all over the UK, working with children and young people who have health conditions, health experiences, friends who have health experiences, or actually children and young people that are just interested. Because one of our key things is reminding everyone that they're children and young people first, their healthcare experience second. And that's one of the kind of like principles of our approach. So I'm here today to represent them and to share some of the things that are important to them. We've got a couple of videos and also some of their voices through the voice bank. But there's so much more that we could have said and that they could have shared with you. So I'll leave some links up at the end as well so that you can look at that yourself. But like I said, my professional background is as a youth and community development worker. I'm really proud now that there's over 130 youth workers working in health settings or in hospitals, and it's really been increasing over the last couple of years with some really recent funding as well from different charities, but also NHS England. And, just thinking about what you were saying, Lucy, they're an amazing extra resource that are really there for children and young people in some of the hardest times, but that can engage with them in a completely different way. So if anybody wants to find out more about that, then I'm happy to speak about that at the end. But to start, we should have a video from the children and young people that will tell you about RCPCH and us.
Over 800 children and young people from across the UK have gotten involved with RCPCH and us and have volunteered over 1,000 hours of their own time to help out.
What does RCPCH and us mean to me? It means empowerment, positive change,
inclusive place where children and young people are able to take part regardless of their life experiences.
voices being heard.
Gives me a chance to share my views on what I believe should be happening for young people in the country.
To have a say in what healthcare should be like for them now and in the future.
And making a difference to improve services for others.
The system being positively challenged.
It gives all of its young volunteers a safe place to talk and speak their minds.
My one child health wish for the future is for children to have a better understanding of their health conditions and how they can be involved in their own care.
So first up, I know there's a lot of white coats in that video, and we don't wear white coats. But it's something that for the young people kind of signifies for them if they're trying to explain that it's about hospitals. And I think that thing that we have to remember is sometimes our perceptions are not the same as their perceptions. So we're really lucky. So I work for the Royal College of Paediatrics and Child Health, which is really complicated to sign, I've learnt tonight. And that organisation, we're really lucky that actually we don't just focus on paediatrics and the specialist paediatricians and the work that they do, but it is the broader child health, which is why it's so important then to really think about actually where children and young people are within their journey in health. Because actually for them, what they've told us before is actually everyone's kind of a doctor or everyone's a nurse. They don't necessarily know all the different places they're coming from. So whether it's GPs or paediatrics or physicians or anaesthetists, they're all people that are there to help them. And sometimes the words that we use, we can then get hung up on, and actually they can create some of the barriers and blocks to the system that then become really challenging for children and young people. RCPCH and Us is our programme then that really involves them in really trying to make a difference and empower and have some agency back, particularly if they have got health conditions, so that actually they're leading that rather than being led by their health condition. But our starting point is the UNCRC. So hands up or emotions and like yellow hands if you're online. Have any of you heard of the UNCRC? Fab, so a few people. And for the people that pop their hands up, can you think about 5 different articles and how it relates to your work in a relevant way? Some of you can, fantastic. So this question came directly from children and young people. The UNCRC is the United Nations Convention on the Rights of the Child. And it was written in 1989 as a way with some countries came together across the world to make sure that there were children's rights, that they were there to protect children, to be able to provide the best services, to promote their rights, but also to have their active participation. So there's 54 different articles which kind of then tell states and governments how best to support and protect children and young people. But one of the key bits is to do that with them. And for us at the college, this is really the framework of everything that kind of like bases the way that we then engage. And we spoke to our children and young people, and we do this, every year to see which children's rights they think are the most relevant ones to talk about in a forum like this. And these are the 6 that they've selected. And it's interesting, so there's a new one that I'll go through in a second. So Article 12 is the right for children and young people's voice to have a really active role in impacting the decisions that affect them. And in the statute, it actually says that that's individually, but also collectively. So for children and young people that have got health needs, they've told us then, that for them that means being really involved in those healthcare decisions, in those individual appointments, but actually in the service design as well, and bringing their collective voice together to kind of like shape action. Article 23 is the right for children and people with disabilities to lead a full and active life. And for our children and young people, they've said that means that actually they have double appointments, they have communication aids, they have communication maps, they have people that ask them which is the way that they want to be involved if they've got disabilities in their healthcare treatment, their processes, and making sure their understanding is embedded. Article 24 is why there's events like this, so the right to the best healthcare possible. 27 is a new one, so that's come this year. I mean, it was written in 1989, but our children and young people have now prioritised it, because actually it's about the right to a good standard of living, so having the right food, the right housing, and for them the cost of living is something they're acutely feeling, particularly if they've got health needs. Article 28 is the right to education, so for children and people with health needs, they would love us to co-locate our services so they don't have to miss 5 days from school to see 5 different clinical teams in 5 different places. But also for their health needs to be understood at school, and there's a role for health in how we do that well. And then Article 31 was selected because it's the right to rest, relax and play, not because they want to have time away from doing activities or events, but because actually if they've got health needs, they need help to be able to engage like everybody else. We were doing clinic chats around the country where we go and ask children and people with health needs what matters to them. And, one of them said, well, what matters to me is being on the school trip but not wearing the red folder around my neck that's got my emergency healthcare plan in. Because actually all 100 people can see that red folder, and so can all the other schools that have come on the trip as well. So it would just nice to be like everyone else, getting on the bus, or even getting on the bus without my parent, because everyone else doesn't have to bring a parent to do the care needs. So those are all the rights that are, they're all important, but some of the ones that our children and young people said were most relevant. So within RCPCH, our approach to engagement and voices and making sure children and young people are really actively involved starts with fun, because they're volunteers, they're children and young people first, and actually whatever our needs might be about asking questions and getting input for standards or guidelines, we need to come at it from where they're at. So being fun, being joyful, being present, and being, developmental in terms of socialisation. Because again, if they've got health needs, sometimes they can't go to all the clubs and groups that everyone else can go to. A third of it is about their agenda, because of going back to Article 12, and their right for their voices to make a difference and really impact the future. And then a third is our agenda, because there's a reason why we've brought people together. And that shift in power is so important, because ordinarily when you think about engagement, it's everything that we need to take from you, and then maybe we'll have a bit of fun at the end. And ours is, a third of it is about our stuff. The other bits is all about you as people. And that's kind of coming from our youth work principles in the way that we run our programme. It's asset-based, so we don't start by going, what's the worst thing that happened to you when you went to the doctors? We start with, what are your wishes or your hopes, or tell us, some of the things that everyone should be able to access and see and be supported by. And we always have a real mixture of children and young people. So the numbers that Aisling said at the start was for one particular part of that year. There's been 11,000 children and young people, ages 0 to 25, probably the youngest is 3, 3 to 25 across the whole of the UK since we've been running the programme over the last 8 years. And we really go out of our way to make sure that we visit them where they're at, to make sure that actually they can be engaged. It's not about bringing them to a random organisation called the Royal College of Paediatrics and Child Health that they've never heard of on a Tuesday afternoon when they're meant to be in school to answer questions about something that sounds really intrusive. So, we try and shift the balance a little bit. So the young people have created a little video as well, which is about being a child, but also then being a child with a health condition.
Childhood is filled with creativity,
Fun.
Kindness.
Adventurous.
Curiosity.
Willingness to do anything.
Complicated.
Freedom. Memories.
Family.
And friends.
However, childhood with a health condition for some can be filled with confusion in regard to that health condition.
Childhood with a health condition for some is isolation.
People sometimes have the wrong perceptions and ideas of what is right and wrong for my condition.
A lack of education due to various medical appointments, which can lead to a stigma being built around the health condition.
Childhood with a health condition for some is misunderstood.
Hard to understand if not known, invisible conditions.
For some, it's feeling like there are inherent disadvantages, but there shouldn't be.
You're not always believed about your condition, especially what worked and what doesn't work.
The wrong idea that it's fun because you miss a day of education.
Seeing us as people, not patients.
And that last bit is really one of the key messages that our children and young people want people to really think about, is to try not to call them patients. They're children and young people, they've got names, they've got interests, they've got fun things that they like to talk to you about, and for us to be really present in where their lives are at, rather than how they're coming to our service and might be meeting our needs of working with patients that day. Just briefly before we go into the panel, there was a few bits that we've been collecting in our voice bank of children and young people and what they think about different health services or what could be better. This one is about health inequalities and the real impact that there is on some children and young people, where not everything is equal and fair. And when we went around the country and asked children and young people from ages 7 to about 21, we asked them, what were some of the things that keep you healthy, happy and well first? And then what are some of the things that for some children and young people might stop them from all being healthy, happy and well? And what could we do to support that? They've written a letter to decision makers called Everyone Deserves the World, because for them it's that simple. And, they're really putting the responsibility back on us to understand that it could be because they've got disabilities, it could be because they've got no money, it could be because of stress, that actually they're some of the things that are leading to worsening health outcomes. And it's really awful to have gone around the country and hear that one of the things in their idea bank was that actually we should have bed banks, because so many of them were saying that they're not got good places to sleep, and they recognise that that's really having an impact. So as well as having food banks, could there be somewhere that could maybe loan out some decent mattresses? Because I think we underestimate, going back to the standard of living point, just how many people are sharing or, having to make do and having to, maybe not have the right housing that then supports their health needs. So do have a look at their letter online. We've just done some work with AYPH, which is the Association of Young People's Health, and the Race Equality Foundation and Young Epilepsy, to really look at what are the different challenges that are faced for young people who face marginalisation, but also maybe have epilepsy or diabetes type 1. And, one of the key things is that not all the words translate beautifully. So we think we're saying things clearly, but in other community languages, the words aren't the same. So we need more time to be able to explain those concepts, to back that up with pictures, back that up with, learning kind of like materials that are really focused on the community or the age or the stage. And that kept coming out from the children and young people we were speaking to. It's been really useful for us to have someone who also uses Punjabi as one of their community languages to be able to swap into that. Or if I go out and I can use sign language, because when you go through an interpreter, it changes the experience for those children, young people and families. They want us to help reduce the stigma, but also to make technology easier and more accessible to all, because it's really hard sometimes. Some of the apps that are created actually don't zoom on your mobile phone, which can be really difficult then if actually you've got sight loss. And then finally, integrated care. We asked what children and young people wanted or thought about that. They'd really love a free bus to get there. So many of them would like to have health services or feel a slight burden on their family, that they've got complex needs or they have to see 4 or 5 different people. And that costs a lot when you try and take an adult and 3 children somewhere because there's no childcare. That actually they don't want to be the one responsible for carrying around their bags of notes between the different doctors or nurses. And they would like that to be shared in a better way. To have check-ins rather than check-ups, so it feels more personalised. So that language again, and just making some slight nuances from not talking to them and talking about patients, not talking about things that are normal, not talking about things that are, about kind of check-ins rather than check-ups, and lots more. But there's so much there, and we've got so much more online too. But, the message from Children and Young People is, please ask them, involve them. They've got so much to give. And thank you very much.
Thank you. Thank you. So if I can invite Lucy and Molly to come and join the panel. Thanks. Okay, thank you for that. I think that really set the scene for us about listening to children and young people. So can I just kick off the panel discussion then by just asking a general question about what's probably the most important or interesting thing that you've learned from your work with children and young people, and particularly those who are experiencing some kind of illness?
Okay, so I've actually got a tremor, so then it makes it look like I'm about to perform a song, so I have to hold it, otherwise the mic goes somewhere different. I think for me, it's that what I've learned is that their ideas are endless. It doesn't matter what condition we've worked with, what age we've worked with, how complex the topic is that we're talking to them about. They have always got solutions. They have always got ideas. They've always got suggestions, and they've always seen so much more than anyone thinks they've seen. And they've experienced so much more as well. And I think they teach me every day something that I didn't know or I didn't understand, and I feel really lucky to be able to be doing that. I've been there 8 years now, and every day it's something else. We've got young people coming in tomorrow, and I know that I'll leave knowing something that I didn't know before, and it feels like a real privilege to always have that opportunity. So, if you've ever got a problem to solve, just ask children and young people. They're also super good at not spending money. So I think sometimes people think that they're going to come up with extravagant ideas that cost a fortune. They're not. They come up with the things that don't cost anything, that make a huge difference. So I think that's what I've learnt.
Oh, we'll share. So as I said, I'm an adult nurse. I don't have a childhood nursing background at all, but I've worked in the NHS now for about 10 years, and I did lots of different things, but I worked for a little while with inherited heart conditions, in which I looked after families, in particular families that were experiencing brand new genetic diagnoses, kind of really sudden death, bereavement, and kind of understanding the way the family dynamic worked and how that led care decisions. But having said that, I worked within cardiology, and it was probably one of the most paternalistic specialities you're going to meet as an adult nurse. Very male dominated and very paternalistic, and that taught me a lot, to the point where I left for numerous reasons. I wanted to have much more shared care, even as an adult nurse. And I now work, as I said, in palliative and end-of-life care, and actually everything you were saying about the children and young people is incredibly similar to a lot of the reframing we do with people who have a life-limiting condition, or reaching the end of their life. In just, obviously language is my thing as well, as a writer and a poet, but changing the way we talk is so helpful. Check-ins, check-ups, the goal setting. Even somebody who has 2 weeks left to live still has things they want to do, and that's not necessarily a bucket list. It's just what matters to you, what makes you you, what brings you joy. My husband and I back home, we say, oh, that sparks joy, that sparks joy. Joy is still sparked, even, and I think kind of to summarise the question, absolutely, just that the way we kind of reframe care, the way we talk to our patients or our young people, is really, really important, and not to take kind of language for granted, I suppose.
I think one thing that I found really interesting, speaking to adults who had experience of treatment as a child, especially given that we're talking here about sort of the 70s, 80s, is the importance of age-appropriate care. I've spoken to people that were treated sort of 10 to 13 on adult wards for cancer, because it's so rare in children, and just how inappropriate that was, how scary it was. But then on the other end of the scale, teenagers that are treated in paediatric wards with, mainly on these wards, it's infants and really young children. So the importance for them of age-appropriate care and resources.
Thank you. Thanks for that. Some really important stuff there. And can we talk a little bit then about the kind of popular misconceptions around children and young people, and particularly how we can, through, as we kind of framed it around the arts and humanities, how do we dispel some of those misconceptions?
Again, I'm possibly not, I'm very aware we've got kind of children, like young people in the audience, and there's something within me that very much feels this is a question for them if people feel they want to share something, because it's other people's experience. I think, and like I say, I am an adult nurse. I think just to go on what you were saying about age-appropriate care, I was a young person. I was 15, 16 when I had my kind of life-saving surgery for a gastric condition that was slowly, it was a very dangerous condition, really. And I was on an adult ward, but actually because my care was so good and I felt so prioritised, I actually felt like a VIP, which was quite a nice experience, actually. And I think probably... I think something that you've touched upon about hearing from kind of collective voices, but actually just individualised voices, because even just hearing that, actually my age-appropriate care, I was on an adult ward, but I wouldn't have wanted to be on a children's ward because I was 16. I was, grown up. But I don't know, Sarah, whether I'm taking over your event. I just wonder, that seems like or save the questions at the end. It just seems misconceptions. There's people in the audience that might be able to better answer than us, perhaps.
Okay, thanks, Molly. That's a fair challenge. So perhaps some of our young people in the audience might help us with that as we move on to the Q&A section after the discussion.
Just on misconceptions, I think one of the things that comes out from our group is that they're often seen as the same. So we categorise children and young people as children and young people, and that's it. We don't break those groups down. And even within the same condition groups, they're different children and young people. So one of our models is about making sure that we work with children and young people that are children and young people first. So we kind of recruit them through universal settings. So schools, youth clubs, community events where actually they've just got an interest and they want to make a difference. Children and young people that have got different experiences. So maybe they're young carers, LGBT groups, maybe they're from faith-based groups. And then specialist children and young people who have paediatric experience with long-term conditions or life-limiting conditions. But when they come to the group, people just say their name and where they're from. Nobody needs to know who they are. They can share what they want to of them, and they can add to the story and add to the discussion as they want to. And I think that's one of the biggest misconceptions that comes out to us is they're not all the same. They all need to be spoken to in a really individualised, like you just said, and personalised way, but in a way that respects what they want to tell you at that time, and that we then need to remember that could change because they're forming their identities, they're learning about themselves. And actually, maybe what was important to them a couple of weeks ago might have changed, and they ask us, can we keep checking in with them? Because we kind of need to grow with them sometimes.
Yeah, very, very true, isn't it? We can't just put a broad brush across people, and just because they're a certain age doesn't make everyone the same, does it? Okay, anything else anyone wants to add around that part of the discussion? So one of the things that you touched on, Emma, in your talk just there was around inclusion of young people. Can we talk a little bit then around why we think children and young people's voices can be excluded sometime or not heard? We may give them opportunity to speak and then not do anything with the information that they give us. Can we talk a little bit about that and what we do differently? How do we make sure that we really do properly listen to all young people?
So I think for us it's part of our training anyway as youth workers that we work in an anti-oppressive, anti-discriminatory way. So that's kind of like inbuilt in the way that we set up our programmes. And I think that one of the reasons why children and young people are excluded is because of adult dynamics. So there's core hours, which work beautifully for adults maybe. That's probably when children and young people are at school or at college. So that might be why they're not able to come when they're invited to that focus group that happens on a Tuesday morning. or we're telling children and young people that they need to stay safe online and they need to really watch their personal data, but what we're going to do is send them a survey and ask them to fill out all their details about a very personalised experience, and then send it to someone that they've never met, they've never seen a photo of, they don't understand the organisation, because they're all adult dynamics. And I think that the bit that we can do different is really central to our model, is go where they are. You know, speak to them in a way that works for them. Remember that it needs to be fun. Think about actually how you even introduce yourselves. And there's a lot of stuff, you know, in terms of social work about being, you know, sitting on the floor. And I'm sure that's the same when it comes to, you know, thinking about actually, you know, where are all the posters when we go into hospitals? They're probably at eye level, which isn't the same as a 5-year-old or a 7-year-old. And I think that that's one of the challenges. We exclude them because we need them to fit in our life and in our systems and our services. And actually, you know, children and people are definitely very keen to tell you what they think about something if you ask them in the right way and you've gone to find them. So our model is that we go out and do roadshows and clinic chats in places across the country that other people wouldn't normally go to. We door knock communities where maybe actually they're, you know, people have said that they're hard to engage. They chat for hours. They tell you everything. You know, we're at school gates, or, you know, we make sure that then we think about how we are inclusive in our approaches. So we've got a committee, for example, for the college that works on a Saturday. So the paediatricians come on a Saturday, the parents come on a Saturday, and the young people come. We have audio descriptions of everything we're doing because we know we've got people with sight loss. We've got deaf people, so we know we've got sign language. But actually, we also know we don't send anything out because they're volunteers, and we need to hold the discussion in the meeting and not add a burden to, you know, prepping or getting ready, because that's really adult to send out meeting notes and papers and briefings. So we do it all through games and activities, and that's kind of the way that we manage that.
I don't think I can say anything better than that. I think, again, from my experience as being a nurse, even in the kind of specialities that I've worked in, the NHS is medicalised, full stop. You know, care is medicalised. It's only since moving into palliative and end-of-life care that care, I believe, has truly, I work for a hospice, is incredibly person-centred, truly holistic. We have amazing social workers, arts therapists, physiotherapists, you know, financial welfare teams. We literally take part of every single part of the person. And I think, you know, from being a young person in the NHS and being told, oh, actually, it must be an eating disorder, when it actually, for me, very much was not. Being kind of told what to think, and it's very interesting what you say even about the kind of the optics, as they say, isn't it, in the hospital. It is, but even in the, even as an adult, you're a lot more privileged in a lot of ways, but it's a medicalised world you're walking into, and I think I'm kind of apprehending one of the questions, but that I really just am quite passionate about people trying to, as best they can, take control of their own care, but that, of course, is hard in a lot of socio-economic ways as well. So,
to add anything, Lucy?
Yeah, just from a historic perspective, of course. I think one thing that is hopefully got a lot better, but I think history acts as a warning about, is children's awareness of their own illness and their need for information about it. And I think sometimes, thinking back to kind of the 70s, 80s, but it probably happened a lot later than that as well, withholding information from children who probably already knew that information and needed to have open and honest discussions about it. I wonder if that's because parents want to protect children, which is natural, or they project their own fears of illness onto them. But that's one way that certainly historically children and young people, their needs and voices were not listened to.
Thank you. I think we've talked a lot really in that conversation around how we elevate the inclusion of the children and young people's voice. And I think over the years we've probably got better in clinical care around engaging children and young people in their clinical care. Are we good enough, and how do we get better around involving children and young people in research and policy development? What are your thoughts?
I think that's a question for you two. I think doing things exactly like you're doing and probably exactly like you're doing and trying to involve children in that's why I kind of say it's so lovely to see young people here and should probably be doing a lot of the talking, and obviously you're collecting a lot of their voices and yourself. And actually when I was writing the poem, I used hugely the voice bank to get kind of ideas and themes with a sprinkling of kind of creativity over the top. So I think just, making sure that these events are inclusive for young people or for children to come along and really elevate their voice, and through exciting mediums such as poetry.
I think that for us, that principle of making sure that there are spaces which are appropriate to children and young people, that are children and young people focused, there's a way for them to share their voice in different ways, that there is the right people ready to listen, and we really think about their influence and impact. And that model is called the Lundy model of participation and engagement, which is centred in creating opportunities for children and young people to really have their Article 12 needs enacted. And that works for research, it works for quality improvement, it works for education, for health, all different aspects. But it's really about having that commitment to a rights-based approach, and knowing that actually if you start with the children's rights agenda, you work with children and young people on understanding what the opportunities are, they'll want to be involved in as much as possible, but they might not want to be involved in everything. And different children and young people might want to do different bits. And I think that's one of the elements for us to take on board, as to particularly maybe for research, is to think about, it's not just about being research participants or involved in research design. It's every element in between, before, after. And actually, that might be 30 different children and young people that want to do those bits, not the same core group. So it's about building that flexibility in your model to have everyone coming in and doing different things at times that are right for them.
Okay. Lucy, did you want to add anything from a research perspective?
Thank you. Just trying to get firsthand these grown people's experience, I think has been important. Some of these people weren't listened to or, had their autonomy respected when they were children and going through treatment. And so I think it's been a real privilege for me to listen to their stories. They've been so interesting and they've helped with the research a lot. But I do think people have kind of found it important to say what happened to them and what their experience was. And that's, we should be trying to encourage that as much as we can. Yeah.
It's always fascinating, I think, how an experience stays with an adult. So you might be talking to someone 50 years on from their experience, but they remember it very, very well. The impact that we have as professionals on those young people can't be underestimated, can it? Okay, so I'm going to open up to questions in the interest of time. So we'll start with the chat from Zoom first this time. Sarah, have we, and Lucy at the back there, have we had any?
Nothing yet, but it takes people a little bit of time to type. So.
Yes, we'll come back to check in afterwards. Anyone in the audience got any questions for any member of the panel or any comments about the discussion? And of course, we have another tote bag for them. Kath Evans is the winner of the tote bag.
Thank you. Really, really interesting reflections. And Emma, I wanted to just pick up on one of the things that you actually said. You said, our voice bank is from 3. That's fantastic. I think traditionally we engage with slightly older children and young people. We promote shared decision making. I don't think we always get it right, and we don't do it consistently. But I am really interested in those younger voices. So nationally, the CQC survey asks from 8 to 11 and then 11 plus. So our policy agenda isn't supporting hearing those younger voices. So I'm really, really interested, particularly given the theme of arts and humanities, as to how we can utilise that to really empower and work with younger children.
Yeah, I mean, great pickup in terms of our age range, and we're really focused on the fact that we make sure that we go out to all ages. So the kind of like training that I had ages ago was from the National Children's Bureau on something called the Mosaic approach, which is a way that you can actually work, and it's predominantly at pre-3-year-olds, so kind of like 6 months to 3s, about how through a mixed methods approach you can really see what's important to them. So kind of like crawling around with them, seeing what spaces in an environment they go to that they naturally will take you to, what areas that actually they don't feel as happy with, doing a 360 evaluation by talking to different people within that kind of like child or infant's life, and seeing what are the things that they are observing themselves, doing your own observations, using trigger objects, using pictures, using a whole range of different things. You can pick up such a clear story. And we have one that we use called Box Stack, where we have loads of different cardboard boxes. We have on each side a picture or a word, and we get them to kind of like just build up their kind of like box tower of things which are important to them when they maybe go to child health services. And it's amazing how there's always some blank ones so they can add to it, but they know what's important, they know what they like, and then they can we can take photos, we can do thematic analysis, we can see which was at the top, which was at the bottom, what was the most important. They love kicking it down at the end or, knocking it over, but it's about being creative in the way that you do that. And actually, there's no reason why policy drivers can't involve that as well. It doesn't all need to be the top end, but also we can't exclude the top end of 16 to 25-year-olds because they've moved into adults, because actually they are young adults and they still need our support as well. So I think we've got challenges in policy with the younger age, like you said, Kath, but also the slightly older ones sometimes are lost into adults, and there's some work to be done there as well.
Anything to add, anyone? No? Okay. But yeah, really important listening to the young children as well. Okay, any other questions from anyone? No? Oh, yeah, there we've got a question there.
Hello, my name's Bridget. I'm a student nurse, actually, a children's student nurse. And I have a question about just transitioning. What are the challenges now? And like you just mentioned, about being lost in the system. So I'd just like to get more of an idea of what is actually going on this time with those young people that are transitioning, that have long-term conditions going into.
Thank you. That's a brilliant question and really important. And again, I caveat it with I don't work as a paediatric nurse or in transition services, but I work with adults and I work with young adults who have a long-term condition or a life-limiting condition and are suddenly thrust into adult services and expected to navigate that in every chaotic way possible, when they are very used to using a caregiver to help make their decisions with them, which is completely appropriate. It's very, very different being an adult in the NHS to being, in kind of child health services. Again, I couldn't probably confidently say they're not up to scratch, but I don't think, I put it back to, I'm getting some nods. I don't think they're up to scratch at all. My speciality prior to this was very niche, very, very niche in inherited cardiac conditions, very rare conditions. Really, and then you make that even smaller, the young people that come in, even smaller with a genetic diagnosis. But we were really kind of spearheading a lot of that research and doing really, really good stuff to kind of improve that. And I know the Great Ormond Street are, absolutely the top people to be doing that. But more work needs to be done. I think coming into the NHS as an adult is chaotic anyway, let alone with, childhood cancers or something like, I've looked after so many people with sickle cell, and that is just a whole nother session, really, isn't it? People just not being, and we could get into a lot of other things in terms of, institutional bias, racial bias, things like that, but that's another session, I think, isn't it? So.
This is working out. Transition is a hugely complex area, isn't it? And an area where we need adult commissioning to look at what's being commissioned for those young people to transition into. And I think, again, lots has happened over the last few decades, but there's always more that can be done. It's a huge shock to a young person who's already going through a massive developmental and emotional change, to then transition into a completely different service where you don't know people. Emma?
I was just going to say that, yeah, from the young people, young adults that are part of our programmes, something that you said, Lucy, about age developmentally appropriate healthcare. So, you know, having those conversations about when is the right time for you to transition. Because actually for some it's 14, you know, some it's 16, some it's 18, some it's 24. And making sure that that's built into the system. Using resources like Ready, Steady, Go from Southampton, and, you know, thinking about how you can embed that in. Nice guidelines say that we should be talking about transition from year 9. And yet when we go around the country, lots of people have had the conversation at their last appointment. And I remember being outside an epilepsy service with a young person who was crying because they thought that actually epilepsy ended when they finished paediatrics. They didn't realise they were taking their epilepsy with them. There were some other learning needs. But, you know, that should have been a really slow step-up process that started many years before about explaining that. And I just think of some of the young people that we've got working with us at the moment, where it's really different with different conditions. So, you know, some of our young people have gone through transition for 3 of their conditions. They've got 3 other conditions that haven't gone through transition yet. They've got shared care, so it's different in different parts of the system. And the word is that it's just inconsistent. And I think that's one of the challenges that, like you said, we need to work with that. But there are some really good programmes that NHS England are doing where they're actually looking at that in transition, in paediatric programmes, but bringing adults together and starting to work through that with young people and young adults on certain conditions as part of the Core 20+5 work. So there's lots of good we can learn from, but unfortunately probably it's inconsistent would be what our young people would reflect back to us.
Yeah, thank you. Any other questions in the audience? Oh, got a question just there.
How do you think COVID and all the lockdowns impacted the transition care? Because I know for me, I got ill at 14, but I didn't get any help until I was 17, and I was navigating it through COVID. And I'm under 4 specialties, and one of my specialties has been brilliant, and we're doing a really slow transition. But I found I turned 18 during lockdown 3 in January 2021, and I didn't have any last appointments. I just didn't hear from my specialties for a couple of months, and I emailed to check up on them, and I was told, oh no, you're over 18 now, you have to go see another specialist. And I was never really given that transition care, and I was just wondering if that seems to be a common thread with COVID, because I know all my other friends who have similar conditions to me found really similar incidents happening with their care.
Thank you. Hugely challenging time, and that must have been so difficult because you didn't have an ending, did you, and a point that you moved on. Thanks for that question. Does anybody want to take that?
Yeah, I was going to say thank you very much for sharing. And it's something that we've heard as well from our groups, unfortunately. Back to the inconsistency. Some had good experiences. They were getting videos sent to them of where maybe they had other specialities working in the MDT, who were videoing what it would look like when they walk into adults, because they weren't able to do those shared appointments. And then we have other experiences very similar to yours where, you know, 2 years on, they're still waiting to have their first appointment and to be matched up. So I think that for us, that there's a lot of damage that we need to understand and that we need to focus on in about how we repair some of that together. It's not that the lockdowns have finished emotionally. They haven't for many of our children and young people or young adults. One of the things we did, we set up something called COVID Book Club, which was young people coming together during lockdowns to not read interesting books, but to look at some of those challenges and think about how they could reflect on it weekly and then share that back to government or share that back to policymakers. So one of the things that we did was try to turn it into a learning opportunity, but also to pick up some of those support needs that were going unmet at the time. Unfortunately, it was really small, but hopefully, you know, some of that learning, you know, did have an impact and help to change some of the practices. But there's so much more that we need to keep doing. And I think the message from tonight is for us all to take that back and share that when we have our team meetings or when we have our practice supervision meetings and just reflect back, actually, what do we still need to do about some of those experiences and checking back in with people?
Okay, does anybody want to add anything? Yeah, I think for me, I would say, find the people that are asking people their opinions and share your story, because that's how we change policy, and make sure that the services are right. So, Health Watch or the likes of Emma's team, or, find people that can hear your story and translate that back into service development. Okay, I'm going to draw our panel to a close. I'll just check in with Sarah there, whether we've had anything else on the Zoom chat.
No, there's no questions coming on the Zoom.
Okay, thanks, Sarah. Okay, so I'm just going to elevate back over here. Swap microphones. Whoops. Wrecking his kit. He didn't see that, did he, at the back there? He didn't see me breaking everything. Okay, so we're drawing to a close now, reaching the end of our event. So huge thanks to everybody for staying to the very end. I think it's been a really useful discussion that we've had. I think there's been some real kind of points for me that have come through. I think Molly's poem absolutely set the scene for us perfectly, so thank you for that. I think our reminder about children's rights from Emma was very pertinent, because some of us in the room will have worked with children for a very long time, but I bet we can't list them. So I think we've all got a bit of work to do and go away there and do a bit of reading up. I think Lucy really kind of shone the light on the massive changes in cancer care, and that could be said for lots of other long-term conditions as well, things that have changed over the years. And I think the message for me throughout is we need to prioritise listening to children and young people and not treating them all as one homogenous blob, because that's not what they are. They are individuals. And we need to learn from them and respect their opinion and make sure we do something with it. So I think there's been some really important messages coming through from our discussions tonight. So thank you so much to all our speakers, and thank you to the team that organised this evening's event, and most importantly, thank you to you and to our people who joined on Zoom. So before people go, I think there are some evaluation surveys around. Sarah's waving them to us at the back there. So if you wanted to grab one of those just to evaluate how you found the evening. And on Zoom, I think the link is being posted in the chat. So the chat will stay open for a few minutes after we finish, just to give people a chance to click on there. But just once again, a huge thank you to our speakers. So we'll give them another round of applause. And thank you. And I just must say, final word, the young people in the audience, is there anything else you wanted to say as our final thought to take away with us? No. Well, I hope it's been useful to you all. Thank you so much. And good evening. Have a safe journey home.